Good morning, guys. It is Mrs. Page, and we are going to be talking about chronic inflammatory bowel disease. First, we'll talk about ulcerative colitis. This is widespread inflammation of mainly the rectum and the rectosigmoid colon, but it can extend to the entire colon. There are periodic remissions and exacerbations, and the intestinal mucosa becomes ulcerated, edematous, and thick, and that leads to a narrowed colon and possible partial bowel obstruction. Risk factors are going to include genetics, usually autoimmune dysfunction will put them at a risk for this, ages between 15 and 35, and women are more common than men in the younger years, but men are more common in the middle age or older years. Signs and symptoms of ulcerative colitis: there will be stool that contains blood and mucus, tenesmus, which is the unpleasant and urgent sensation to defecate, lower abdominal colicky pain that's relieved with defecation. You might also see some malaise, anorexia, anemia, dehydration, fever, and weight loss. Assessment: history-wise, you want to ask about a family history of ulcerative colitis, previous or current therapy for the disease, any types of surgery, nutrition history, bowel elimination patterns, recent exposure to antibiotics, recent travel, and any kind of NSAID use. Physical assessment is going to be asking them about symptoms, getting some vital signs, and completing a focused GI assessment. Psychosocial assessment: you want to ask them if they have any concerns, especially about the frequency of stools and the presence of blood. Does the ulcerative colitis interfere with ADLs, such as do they have to go to the bathroom, or do they have to be around the bathroom, or do they have to feel like they're close to the bathroom? What are their feelings toward eating, stress, and do they have any support systems? Laboratory tests for ulcerative colitis: the hemoglobin and hematocrit H&H levels will be low from chronic blood loss. Increased white blood cells, CRP, which is C-reactive protein, and ESR, erythrocyte sedimentation rate, is going to indicate an inflammatory disease. Sodium, potassium, chloride will be low from the frequent diarrhea and malabsorption. Diagnostic tests: there's an MRE, which is magnetic resonance interrography. They should be NPO 4 to 6 hours prior to this test. They'll drink contrast media, and then an MRI is done. Glucagon will be given sub-Q to help slow bowel activity and motility so that they can get a better picture. They can also have upper GIs or colonoscopies done, CT scans, and a barium enema will be used to differentiate ulcerative colitis from Crohn's disease. Interventions for ulcerative colitis: non-surgical. They need physical and emotional rest because rest will reduce intestinal activity. Record the color, volume, frequency, and consistency of stools. Monitor the perianal skin for irritation or ulceration. Monitor their weight. Nutrition therapy: they will be NPO in the hospital to allow for bowel rest, so they might be on TPN. They should avoid caffeine, alcohol, smoking, carbonated beverages, nuts and corn, raw vegetables, or other high fiber foods that can cause GI symptoms. Drug therapy for ulcerative colitis: aminosalicylates will be used to treat mild to moderate ulcerative colitis and or maintain remission. Sulfasalazine, which is the same class as sulfa antibiotics, so make sure to assess for a sulfa allergy. And then there's also mesalamine. Glucocorticoids are prescribed during exacerbations to help with inflammation, so prednisone, prednisolone. Antidiarrheal drugs can be given, but they are given cautiously because it can cause colon dilation and lead to toxic megacolon. Immunomodulators will alter the immune response. This is used in combinations with steroids to offer a quicker response and use a lower dose of steroids. There's Humira and Remicade and some other medicines as well. There's also complementary and integrative health, such as herbs, vitamin C, hypnosis, yoga, and acupuncture that can be used. Surgical interventions for ulcerative colitis. There can be minimally invasive surgery or open conventional. It really depends on the patient's weight, history, and scar tissue. The restorative proctocolectomy with ilio-pouch anal anastomosis is the gold standard for ulcerative colitis patients. This is the removal of the colon and most of the rectum. The surgeon will create an internal pouch using the last 1.5 feet of the small intestine. This is known as a J pouch, S pouch, or pelvic pouch, and it's connected to the anus. And then a temporary ileostomy is created to allow healing of this internal pouch. Then a second surgery is done and the ileostomy is closed, and then the small intestine is connected to that pouch, usually about 1 to 2 months after the surgery, and then normal bowel habits will return. There's also the total proctocolectomy with permanent ileostomy. The colon, rectum, and anus are removed with a surgical closing of the anus, and then the ileum is brought through the abdominal wall to create a permanent ileostomy. Pre-op for these surgeries, antibiotics are given within 1 hour of surgical opening. Post-operatively, they'll be NPO, they'll have NG tubes and drains, control the pain, control diarrhea, and monitor for signs of a GI bleed. Ostomy care. We should know a lot about ostomy care because we learned it in 101 or 102. But as a little review, output from an ileostomy is going to initially be loose and dark green with some blood in it. Then it's going to change to a thicker consistency with yellow to green or a yellow brownish color with a slight odor or a sweetish odor. If there's a foul odor, then that can indicate infection. An ostomy will constantly drain, and it is very irritating to the skin. So skin care around the stoma is going to be really important. You want to collaborate with the wound care nurse and help the patient adjust to the ileostomy. Teach the patient to avoid foods that cause gas, like high fiber, nuts, raw cabbage, corn, celery, apples with peels, or popcorn. Include adequate levels of water and salt in the diet because the ileostomy increases the loss of these substances. Case manager or social worker can be collaborated with for community groups, supplies, or other needs. Change the entire pouch system every 3 to 7 days, but change the bag when it's 1/3 to 1/2 full. They should avoid enteric-coated and capsule medications because these do not absorb well. And if drainage stops, remove the pouch, put the patient in the knee-chest position. You can give them an abdominal massage, apply moist towels to the abdomen, or hot tea. And if nothing works, then contact the healthcare provider. Crohn's disease is the chronic inflammatory disease of the small intestine, most often the colon or both. It involves multiple regions of the intestines with normal sections in between, and these are called skip lesions when they are seen on the x-rays. This Crohn's disease also has remissions and exacerbations, and the inflammation that can cause a thickened bowel, strictures and deep ulcerations, which show a cobblestone appearance, will occur, and this leads to diarrhea and malabsorption. Risk factors include family history, tobacco use, Jewish ethnicity, and living in urban areas. Signs and symptoms of Crohn's disease. Bowel sounds will be decreased or absent. Borborygmi, muscle guarding, masses, rigidity or tenderness during palpation, diarrhea, low-grade fever, and that's common with fistulas, abscesses, and severe inflammation, steatorrhea, bright red blood in the stool, abdominal pain in the right lower quadrant around the umbilicus or lower abdomen, and weight loss. Assessment, you want to start with the history. Do they have any recent unintentional weight loss? Ask about the frequency and consistency of stools, blood in stools, fever, or abdominal pain. A physical assessment will include the focused abdominal assessment and nutrition and hydration status. Psychosocial assessment, ask about coping skills, support systems, and if they have depression or anxiety, because a lot of times these will occur with Crohn's disease because of how taxing it is on the body. Laboratory test, CBC, specifically looking at the H&H, red blood cells, because anemia can be shown from slow bleeding and poor nutrition. Folic acid and vitamin B12 levels will be low. Decreased albumin levels, CRP and ESR are going to be elevated from inflammation, and fluid and electrolyte losses from diarrhea. Diagnostic tests are going to be X-rays, MRE, abdominal ultrasound, CT scan, or GI bleeding scan. Non-surgical interventions for Crohn's disease will include drug therapy. They will be on immune system suppression drugs such as methotrexate. They might use monoclonal antibody drugs to help with periods of exacerbation, or glucocorticoids. These are used cautiously because they can mask symptoms of fistulas and abscess formations. Nutrition therapy, these patients might need TPN if they're in the hospital. Nutritional supplements can be given, and they should avoid GI stimulants. Fistula management, which is common in Crohn's disease. Fistula is an abnormal tract between two or more body areas. You can see a picture of this is a drawn picture of a fistula right here, where there's a connection between two or more areas in the body. There's enterovesical between the bowel and bladder. They are at risk for intra-abdominal abscesses and sepsis. Antibiotics might be prescribed for these, and you want to monitor for signs of sepsis. Enteroenteric, which is between two segments of the bowel. Enterocutaneous is between the skin and the bowel. They're going to be at risk for skin breakdown and infections. And enterovaginal, which is between the bowel and the vagina. You can see here there's a picture of what it would look like on the outside of an enterocutaneous fistula, so between the bowel and the skin. And then here is a picture of what you would see on maybe an X-ray, MRI, CT scan. I think this is a CT scan. And you can see that this is the fistula from the bowel to the skin right here. Complementary therapies that might also be used for Crohn's disease are herbs like ginger to help soothe the GI tract, acupuncture, hypnotherapy, and possibly yoga. Surgical management, they might need surgery for fistulas, perforation, massive hemorrhage, intestinal obstruction or strictures, abscesses, or cancer, which are all complications of Crohn's. They might also need a resection of the small intestine and a stricturoplasty for bowel strictures. You can see here in this picture, this is a stricturoplasty. So a stricture is the narrowing in the intestines that's caused by Crohn's disease. They'll go in, they'll make an incision. They will make a new opening and fold the incision together, and then it's a slightly shorter intestine, but there's not going to be any kind of stricture there, so nutrient absorption is not going to be affected. Home care management, patients with Crohn's disease should have easy access to the bathroom. You want to teach the patient about the disease, symptoms of complications, and when they should contact their healthcare provider. The need for drug therapy and vitamin B12 injections. Remember that vitamin B12 is absorbed mostly in the small intestine, and that is where you will find a lot of the problems with Crohn's. So this can affect the absorption of vitamin B12. They should eat high-calorie diets and avoid foods that cause discomfort like milk, gluten, or GI stimulants. They will need rest periods during exacerbations. Teach them about stress management and proper ileostomy care if they do have an ileostomy. Comparing and contrasting ulcerative colitis to Crohn's disease. Similarities is their both cause is unknown. They both affect primarily the young adults, but they can also affect older adults. They are chronic and recurrent diseases, and diarrhea is going to be the predominant symptom. The difference is ulcerative colitis is going to affect the large bowel in a continuous type pattern, and surgery can cure ulcerative colitis. And you can see here that this is a picture of ulcerative colitis where it kind of affects most of the large bowel and in a continuous pattern. Crohn's disease primarily affects the small intestine, can also affect the large intestine, but it occurs in a patchy pattern. So you can see here's a patch, over here. And surgery for Crohn's is usually just palliative. Complications of ulcerative colitis and Crohn's. Now, both of these conditions can have all of these complications, but this is what's seen more frequently in ulcerative colitis versus Crohn's. So ulcerative colitis, you'll see hemorrhage, toxic megacolon, colon perforation, and colorectal cancer. In Crohn's, you'll see malabsorption, fistulas, intestinal obstruction, abscesses, perforation, and osteoporosis. Next, we'll talk about diverticular disease. So diverticula is the pouch-like herniation of mucosa through a muscular wall of any part of the gut, most commonly in the colon. Diverticulosis is the presence of many abnormal pouch-like herniations, and diverticulitis is the inflammation or infection of these diverticulosis. It can occur in any part of the small intestine or large intestine, but mostly it is in the sigmoid colon. The muscle of the colon will hypertrophy, thicken, and become rigid. An undigested food or bacteria can become trapped in the diverticulum. The blood supply is then reduced and diverticulitis occurs. And this can perforate, lead to abscesses, which can lead to peritonitis. Diets that are low in fiber and a frequent history of constipation can also cause diverticula. Signs and symptoms of diverticular disease. So diverticulosis is usually asymptomatic, but diverticulitis is when this comes to light. There is abdominal pain, usually in the left lower quadrant, nausea, vomiting, low-grade fever, chills, tachycardia, abdominal distension, and rectal bleeding or bleeding from a perforation of the diverticulum if that has occurred. You can see here are these pouch-like herniations. This is what it looks like inside of the intestines. You can see that's where food can become trapped in there and cause infections. Laboratory tests, there will be an elevated white blood cell count because of infection, a decreased hemoglobin and hematocrit if it's chronic or severe bleeding is occurring, and a stool test for occult blood will be positive. Diagnostic tests, we'll do x-rays to check for peritonitis, CT scan, or abdominal ultrasound. A colonoscopy will usually be done 4 to 8 weeks after the acute phase, just to rule out a tumor, especially if rectal bleeding is present. We don't want to do it during the acute phase because it can cause more harm than good. A lot of people will come into the ER because they are having pain from diverticulitis, but there are specific reasons that a person might need to be hospitalized for diverticulitis, and that would be if the fever is higher than 101, if they have persistent and severe abdominal pain for more than 3 days, or if they have a lower GI bleed. Most of the time, a patient will come in and have diverticulitis and can be sent home on antibiotic therapy and pain medicines. Non-surgical drug therapy will be a broad-spectrum antibiotic, mild analgesic, IV fluids, and You should avoid laxatives and enemas because this will increase the pressure in the colon and it can cause the diverticulum to rupture, which is not what we want. Nutrition therapy, they need to be on low fiber or clear liquids during the acute phase, and then the diet can return to normal after inflammation and bowel function returns. They might be on they might have an NG tube, might have some IV fluids, and they should refrain from lifting, straining, coughing, or bending to avoid the increase in intra-abdominal pressure. Surgical management, they might have emergency surgery if peritonitis, bowel obstruction, or a pelvic abscess is present. They might also need a colon resection with or without a colostomy. It just depends on how bad it is. Home management, they should have a high fiber diet unless they're in the acute phase. Again, if they're in the acute phase, they should have a low fiber or clear liquids, but high fiber diet all of the other times. They should drink plenty of fluids. They should avoid alcohol, avoid foods that contain seeds or indigestible material that can block the diverticulum, such as nuts, corn, popcorn, cucumbers, tomatoes, strawberries, or figs. If they have a colostomy, then teach them about caring for the colostomy and teach them about signs and symptoms that need to be reported to the healthcare provider, such as fever, abdominal pain, blood, or tarry stools. That is all I have for chronic inflammatory bowel disease. If you guys have any questions, please send me an email or bring some questions to the Q&A session.